Hi guys, welcome back. Okay, sorry for the inconvenience. We had a small technical error. I think you guys can hear me now. Okay, so Shabib here with Osium. We'll be discussing a part of physiology which is respiration. I'll be discussing some questions and some topics along with that. So I know you guys are exhausted after this anatomy session. So just be with me. I will take you through the questions. Okay. So let's begin. The first question: which of the following are functions of components of the respiratory system? So the main function of the respiratory system is the uptake of O2 and removal of CO2. This is the main function. Along with this, the respiratory system also has some non-respiratory function, which includes vocalization, olfactory, balancing the uh, acid-base system, regulating the temperature, and warming and moistening the inhaled air, etc. So let's go through the options. The first option is warming and moistening of the inhaled air, which is a function. Delivering oxygen to and removing carbon dioxide from the blood, which is the main function. Assisting in the maintenance of the blood pH, which is also a function. So the correct option will be all of the above. Okay, so just go through the non-respiratory functions, which is an important part. Okay, let's go to the second question. Which of the following is the first branching of the bronchial tree that has gas exchanging capabilities? So the respiratory system is divided into two parts, which are the respiratory part and the conducting part. Okay, so the conducting part basically begins from the nasal cavity, includes pharynx, larynx, trachea, bronchi, bronchioles, till the terminal bronchioles. From there, the respiratory part begins. It begins with the respiratory bronchioles, and it continues through the alveolar duct, alveolar sac, and finally the alveoli. Okay, so the difference is the conducting part just transports the air instead of any gaseous exchange. The respiratory part helps in gaseous exchange because it has alveoli present there. Okay, so the respiratory bronchiole have alveolar openings. Now, so the options: terminal bronchioles, which is a part of conducting part, so it does not takes place in gas exchanging. Gas exchanging. The second one is respiratory bronchioles. It is where the respiratory part begins. That's the question. Which of the following is the first branching of the bronchial tree that has gaseous exchange, which is respiratory bronchioles. It continues to alveolar duct, alveolar sac, and then alveoli. Okay, I hope it's clear. The third question: which of the following could not be a part of respiratory zone? So we have already discussed the respiratory zone and the conducting zone. Which of the following is not a part of the respiratory zone? The parts of the respiratory zone are, as discussed, respiratory bronchiole, alveolar duct, alveolar sac, and alveoli. So the terminal bronchiole is not a part of the respiratory zone. Okay, the next question: regarding transpulmonary pressure, all is correct except, so we should find the wrong statement here. First of all, the transpulmonary pressure is the difference between alveolar pressure and intrapleural pressure. Okay, this is the transpulmonary pressure. It is the difference in the pressures between alveolar pressure and the intrapleural pressure. So let's go through the option. First option, it is the difference between intraalveolar and intrapleural pressure. That is a correct one. Okay, let's check the other options. This pressure is created by strong diaphragmatic occupation, intercostal contraction. Yes, that's also true. It is the pressure which expands the lung. Yes, transpulmonary pressure helps in expanding the lung during inspiration. So that is also correct. It is the pressure between two layers of pleural membrane. No, this is a wrong statement. Okay, the pressure between the two layers of pleural membrane is what? Intrapleural pressure. Okay, so this is the wrong statement. Okay, let's go to the next question. Which of the following represent the pressure difference that act to distend the lungs? Just as we discussed, that transpulmonary pressure helps in expansion of the lungs during the inspiration. So that is what they asked. Pressure difference that act to distend the lungs, which is transpulmonary pressure. Okay, the next question. Intra-alveolar pressure, the pressure inside the alveoli. See, the thing you have to know about intra-alveolar pressure is it is negative during inspiration, positive during expiration, and zero at the beginning of inspiration, at the end of inspiration, and after expiration. Okay, so the intra-alveolar pressure is negative during inspiration, positive during expiration, and zero at the beginning of inspiration, after inspiration, and after expiration. So the options are: is negative throughout the normal quiet breathing? No, it becomes positive during expiration. Is zero during the pause between inspiration and expiration? Yes, it is zero, right? It is zero after at the end of inspiration. Next, is greater than 5 to 6 mmHg during quiet inspiration? No, it's wrong. Is more negative than 5 to 6 mmHg during quiet inspiration? No. So the correct answer will be question number 6. The correct option will be B. Okay. Okay. The next part question. Which of the following is true under normal condition? So the normal breathing condition, which of them are true? Intrapleural pressure is always greater than intrapulmonary pressure. No, intrapleural pressure is always negative. Okay, we know that. The next option is intrapulmonary pressure is always greater than the atmosphere. No, it becomes negative during inspiration, right? Intrapleural pressure is always less than atmospheric pressure. That is the correct option, because intrapulmonary pressure is always negative because of the recoiling tendency of the lung. Okay. The next question, the intrapleural pressure at the end of inspiration. Okay, so let's discuss intrapleural pressure. At the end of normal expiration, intrapleural pressure will be minus 3 centimeter H2O. End of inspiration, it will be minus 6 cm H2O. Okay, so they asked intrapleural pressure at the end of inspiration, okay, which is minus 6 centimeter, uh, yes, minus 6 mmHg. Okay. Okay, the next question, action of the ribs during breathing. Okay, the ribs during inspiration, it increases the thoracic, the volume of the thoracic cavity, right? So the options are carries the larynx downwards, no. Results in the contraction of diaphragm during expiration, no. Diaphragm is contracted during the inspiration. During expiration, diaphragm is being relaxed. Okay. The third option, increase in the anterior, posterior, and transverse diameter of the thoracic cavity. Yes, the ribs helps in increasing the anterior, posterior, and transverse diameter of the thoracic cavity. Okay. The last option is that they are lowered during inhalation. No, they are not being lowered. Okay, they are being raised. Okay, the next question, in quiet breathing, which is in normal breathing, expiration is, okay, we know inspiration is an active process and expiration is a passive process. Okay, we can just discuss the muscles involved, right? In inspiration, the muscles are diaphragm and external intercostal muscles. Okay, in forced inspiration there will be extra accessory muscles. Okay, next, expiration, for expiration, the muscles involved are internal intercostal muscles and abdominal muscles. Okay, during forced expiration. See, in quiet breathing, expiration is, yes, it's passive due to elastic tissue alone. Not only because of the elastic tissue, it's passive because of the surface tension of the alveoli and the elastic recoil tendency of the lungs. Okay, so the option will be B, passive due to surface tension in the alveoli and elastic tissue recoil. Okay, C and D are wrong because expiration is not an active process. Okay, the next question, okay, about inspiration, right? Inspiration, the options are is accomplished by increasing the volume of lungs. Yes, during inspiration the volume of lungs increases. Takes place when the air pressure is in the lungs equal to the atmosphere. No, that's wrong. The inspiration takes place when there is a difference in the pressure. Okay, is accompanied by an increase in intrapleural pressure. No, intrapleural pressure becomes more negative during inspiration. Okay, occurs when the lung volume is decreased. No, during inspiration the lung volume increases. So option A is the right answer. Okay, we'll go to the next question. Which of the following are muscles of inspiration? We have already discussed the muscles of inspiration are external intercostal muscles and diaphragm. Okay, and for expiration will be abdominal muscles and internal intercostal muscles. So the correct option will be diaphragm and external intercostal muscles. Okay, easy. The next question. A healthy 25-year-old medical student participates in a 10-kilometer charity run. Which muscle does the student use to contract during expiration? Again, the muscle during expiration. Okay, I told you it will be internal intercostal muscles and abdominal muscles. Option D. So the three questions from the same topic. Okay, the next question. Which of the following does not happen during inspiration? Okay, let's go through the options. The ribs move upward. Yes, during inspiration, the ribs moves upward. The diaphragm lifts up. No, that's wrong. The diaphragm is actually a dome shaped structure which during inspiration it flattens, increasing the volume in the thoracic cavity. So this is the wrong answer, and they have asked the which does not happen. So option B is the correct answer. The third option is the anterior posterior dimension of the chest are increased. We have already said that the transverse dimensions of the thorax are increased. Yes, both the anterior posterior and transverse dimensions are increased during the inspiration. Okay, next one is forced expiration. It's called hyperpnea. No, involves contraction of internal intercostal and abdominal muscle. Yes, these muscles are used in expiration, right? Is caused by the contraction of both internal and external intercostal muscles. No, external intercostal muscle is contracted during inspiration. Is that in which of the intrathoracic pressure is markedly decreased? No, the intrathoracic pressure is not markedly decreased. Okay, so the correct option will be B. The muscles used for forced expiration are internal intercostal muscles and abdominal muscles. Okay, the next question is the most likely response in a patient with pneumothorax upon entry of air into the chest would be. So pneumothorax is presence of air in the pleural space. Okay, so the intrapleural pressure will be lost, and the lung will have a tendency to collapse, and the thoracic cavity will have a tendency to expand because the intrapleural pressure hold the lungs and the chest cavity together, right? So let's go through the options. The lung collapse inward, that is right, and the chest wall collapse inward. No, that is wrong. The lung collapse inward and the chest wall springs outward. Yes, that's correct. The lung expands outward. No, lung does not expand outward. The lung expand outwards. No, this is also wrong. So the correct option is option B. Clear? Okay, the next question. Type 2 pneumocytes. We know there are three different types of cells in the alveoli, which are type 1 pneumocytes, type sorry, type 2 pneumocytes, and alveolar phagocytes. Okay, so in this, type 1 pneumocytes helps in the gaseous exchange, and type 2 pneumocytes, their basic function is to produce or secrete the pulmonary surfactant. We know the surfactant is used for or helps in reducing the surface tension inside the alveoli. Okay, the surfactant helps in reducing the surface tension inside the alveoli, thereby prevent the collapsing of the alveoli. Okay, so type 2 pneumocytes produce surfactant. Okay, that is the answer. Next question, okay, is about surfactant, just what we discussed now. Surfactant is produced by type 1 alveolar cells. No, it is produced by type 2 alveolar cells. Is commonly deficient in full term neonates. No, it's commonly deficient in premature neonates or preterm neonates, because the surfactant is being produced after 36 weeks of gestation. Okay, so in full term neonates there is no deficiency of surfactant, so this is also wrong. Act as surface tension lowering agent. Okay, surfactant helps in reducing the surface tension inside the alveoli, that is correct. Increases pulmonary edema. No. Okay, so the correct option is C. Is that clear, guys? Okay, next question. Which of the following is not true concerning respiratory distress syndrome in premature infant? So respiratory distress syndrome is nothing but deficiency of pulmonary surfactant. Okay, so the options are their ability to synthesize dipalmitoyl lecithin is limited. Okay, is not true. We should find the false statement about surfactant. Okay, or the premature infants, where there will be RDS, which is respiratory distress syndrome, which means they have deficiency of surfactant. So their ability to synthesize dipalmitoyl lecithin, which is surfactant, is limited. Yes, that's correct. Okay, higher pressures are required to ventilate the lungs. That is, yes, that is correct. No surfactant, so the lung have higher tendency to collapse, so higher pressure will be needed to ventilate the lungs. Lung compliance is low. Okay, compliance is nothing but the stretchability of the lung. So as I said, there is deficiency of surfactant, so the lung will have a tendency to collapse. It will be difficult to stretch the lungs. Okay, so the lung compliance is low. Alveoli tend to over expand and sometimes burst at the end of the inspiration. That's wrong. Alveoli will not expand. This is a character of emphysema. Okay, so alveoli tend to over expand. No, so that is the wrong answer. Wrong statement and the correct answer. Okay, okay. The next question: which of the following cells produce surfactant in lung alveoli? Okay, I told you the in the lung alveoli, the surfactant is being produced by type 2 alveolar cells. Okay, type 2 pneumocytes or type 2 alveolar cells. Okay, also known as greater alveolar cells. Clear? These are just the other names. Okay, the next question: is again about surfactant. So guys, the surfactant topics is a little bit important one, okay, but the questions are easy. The first option is a glycoprotein. No, we said it is dipalmitoyl lecithin along with some apoproteins and calcium ions, okay, is not a glycoprotein. Next is secreted by type 1 pneumocytes. No, it's secreted by type 2 pneumocytes. Increases the surface tension. No, it helps to reduce or decrease the surface tension. So all the first three statements are wrong. The fourth statement is maybe deficient in premature babies. Easy. That's right. Okay. The next question. A major function of the surfactant is to increase. Okay. A major function of the surfactant is to increase. Is it the alveolar surface tension? No, the surfactant decreases the alveolar surface tension. Pulmonary compliance, stretchability. The surfactant reduces the collapsing tendency of the lung, so the lung can be stretched easily. So it increases the pulmonary compliance. Compliance is nothing but the stretchability of the lung. Okay, next is release of O2 from hemoglobin. No, the work of breathing. Surfactant does not increase the work of breathing, it decreases the work of breathing. So the correct answer is B. Okay, surfactant helps to increase the pulmonary compliance or the stretching capability of the lung. Okay, next question is an infant born prematurely in gestational week 25, which is premature infant, okay, has neonatal respiratory distress syndrome. Of course, which of the following would be expected in this infant? So this infant has respiratory distress syndrome, which is deficiency of surfactant. So there is no surfactant, so the lung will be collapse of smaller alveoli. Okay, okay, the next question. A 22-year-old woman has a pulmonary compliance of 0.2 liter per centimeter H2O and a pleural pressure of -4 centimeter H2O. What is the pleural pressure when she inhales 1 liter of air? So it's basic equation and mathematics. Sorry. Okay. We know pulmonary compliance is equal to, what is pulmonary compliance? Change in volume per change in pressure. So the change in pressure will be change in volume divided by compliance. Now we know the change in volume is what? 1 liter. Okay, 1 liter divided by the compliance, which is 0.2, which is 5. Okay, that is the change in pressure. So the change in pressure, which is P1 minus P2, which is 4, is equal to 5. So P1 will be 4 plus 5, 9. Okay, minus 9. Is that clear? It's just the mathematical equation and calculation. Easy. Okay, I hope it's clear. The equation is once again compliance is change in volume per change in pressure. Okay, this is the equation. Okay, the next question. in normally breathing individual maximum amount of work of breathing. Okay, so let's talk about the work of breathing. Two types of works are involved, which are, the first one is elastic work, okay, which is 65% of the work, and the second one will be non elastic work, okay, which the remaining 35 percentage. So the elastic work constitutes elastic resistance and surface tension. Okay, the non-elastic works constitute what? The airway resistance and the tissue resistance. So the major work is done by the elastic work, which constitutes the elastic resistance and the surface tension. So maximum amount of work is required to overcome the elastic resistance and also the surface tension. Okay, the next question. Bronchoconstriction is produced by. Okay, so we should know the factors which affect the airway resistance. Okay, there is physical factors which are intrapleural pressure and the lateral traction. Okay, next we have the nervous factors which are parasympathetic and sympathetic stimulation. The parasympathetic causes bronchoconstriction, means increased airway resistance. Sympathetic causes bronchodilation, leading to decreased airway resistance. Now there are some chemical factors like histamine, leukotrienes, etc. They increases the airway resistance. Okay, so histamine increases the airway resistance by causing bronchodilation. Yes, acetylcholine is a parasympathetic, so it causes bronchoconstriction. Again, vasopressin, no. So both A and B are correct. Okay. Okay, let's go to the next question. Which of the following is the site of highest airway resistance? So you should know that resistance is inversely proportional to the radius of the airway. So we'll be thinking the smallest bronchi will be having the highest resistance. No, there is the special feature for the smallest bronchi. The smallest bronchi, it has a small radius, but it is huge in number. So it has higher what? Surface area. Okay, it has a higher surface area which will reduce the airway resistance. So the highest airway resistance will be in the medium sized bronchi. Okay, next question is the airway resistance will be reduced by. Okay, we have already discussed the sympathetic, the parasympathetic, histamine and all. Blockade of beta 2 adrenergic, which is sympathetic. Okay, so blocking causes what? Blocking of broncho dilation. So the airway resistance will be increased. So this is not the answer. stimulation of beta 2 or stimulation of the sympathetic nervous stimulation, which leads to bronchodilation and reduced or decreased airway resistance. Okay, histamine causes increased airway resistance, parasympathetic causes bronchoconstriction, thereby causing increased airway resistance. So the correct option is B. Okay, let's go to the next question. What tends to decrease airway resistance? Again, airway resistance. We know, yes, option B, stimulation of sympathetic fibers causing bronchodilation decreases airway resistance. In asthma, what happens? There is inflammation, the bronchospasm, so airway resistance is increased. Okay, let's go to the next question. A 25-year-old man breathing through a snorkel has a respiratory rate of 10 per minute, tidal volume of 550 ml, and anatomical dead space 250 ml. What is the alveolar ventilation? So we should know two equations in this portion. First one was uh, pulmonary ventilation, the air transported to the lungs, okay, which is tidal volume into the respiratory rate. Now the alveolar ventilation, which is the air uh, present inside the alveolus, okay, so which is tidal volume minus dead space. Dead space means, in case of alveoli, the alveoli which are not functioning, okay, or the air present in the conducting zone also, into respiratory rate. So we need to find the alveolar ventilation, right? So just put the values. Tidal volume is 550 minus dead space is 250 into respiratory rate is 10, which will be 300 times 10, 3000 ml per minute. Okay, easy, option B. Okay, just know these two equations and put the values. Next question, a similar one. A person with tidal volume 400 ml per breath, respiratory rate of 14 breaths per minute, dead space of 120 ml, have a pulmonary ventilation of and alveolar ventilation of. So we should find both the pulmonary ventilation and the alveolar ventilation. So the pulmonary ventilation will be tidal volume into respiratory rate. Here the tidal volume is 400 and the respiratory rate is 14 breaths per minute. So the pulmonary ventilation will be 5600, right? Yes, ml per minute. Now the alveolar ventilation will be tidal volume minus dead space times the respiratory rate, which is 400 minus 120 into 14, okay, which is 280 times 14, which will be 3920 ml per minute. So the pulmonary ventilation is 5600 and the alveolar ventilation is 3920. Option D will be the correct one. Okay, is that clear? Very easy. Okay, the next question concerning the alveolar ventilation, all is true except about the alveolar ventilation may be reduced while the pulmonary ventilation is normal. Okay, except we should find the false statement. This is a true statement where in case of presence of dead space, the alveolar ventilation will be reduced, just as we just saw in the last case. The alveolar ventilation is lower than the pulmonary ventilation because of the presence of dead space. Is decreased by shallow rapid respiration. No, it's increased. It is increased. Okay, alveolar ventilation is increased. Equals 350 times 16 at rest. No, equals tidal volume. Sorry, is increased, decreased by the shallow rapid respiration. Yes, alveolar ventilation is decreased by the shallow rapid respiration. I'm sorry. Equals 350 times the 16 at rest. Yes, that is also correct. Equals tidal volume into respiratory rate. Is that correct? No, this is what? Pulmonary ventilation. Alveolar ventilation is tidal volume minus dead space into the respiratory rate. Okay, so this is the wrong option. Let's go to the next question. Combined with the systemic circulation, the pulmonary circulation. So the pulmonary circulation, just know that it has reduced blood flow or pressure and reduced resistance. Okay, compared to systemic circulation. Okay, so higher blood flow, no. Lower resistance, yes. Higher arterial pressure, no. Higher capillary pressure, no. It has lower resistance and lower pressure compared to the systemic circulation. Okay, let's go to the next question. The following factors affect the rate of gas diffusion through the respiratory membrane. So for that, we can discuss about the rate of diffusion of gas. The rate of diffusion is the ability for the gases to move across the alveolar membrane, which is proportional to or directly proportional to uh, change in pressure, temperature, area, and surface solubility, and inversely proportional to root of molecular weight of the gas and the thickness of the membrane. Okay, so the following factors affect the rate of gas diffusion. Okay, thickness, yes, thickness affects the rate of diffusion. See, the surface tension, surface area of the membrane, yes, area, and diffusion coefficient of the gas, yes. So the option will be all of the above. Clear? Next question. All about diffusion of O2 across the membrane is correct, except, so we should find the wrong statement. Increasing the first of all, let's keep in mind that rate of diffusion is directly proportional to change in pressure, temperature, surface area, solubility, and inversely proportional to root of molecular mass of the gases and the thickness. Okay, so increasing thickness of the membrane would decrease the flow. That is correct. Yes, it is inversely proportional. Next, increasing the area of the membrane would increase the flow. That is also correct. It is directly proportional. If you increase the alveolar concentration of O2, you would increase the total flow of O2 across the alveolar membrane. Yes, that is also correct. Okay, change in pressure. Last one, the lower the diffusion coefficient, the higher the flow. No, the lower the diffusion coefficient, the lower the flow. Okay, it's directly proportional. So the correct option or the wrong statement is option D. Now, ventilation perfusion ratio. Ventilation perfusion ratio, which is around 6 at which is around 3 at apex and around zero point 0.6 at base. See, the ventilation and perfusion both are high towards the base and decreases when we move towards the apex of the lung. Okay. Now, when we take the ventilation perfusion ratio, it is highest at the apex and lower at the base. Okay. Understand the difference. No, ratio is, first option is lower. No, it is higher at the apex, right? What is the next? Is expected to increase in obstructive lung disease. Let's see. In obstructive lung diseases, the ventilation is decreased, right? So the ratio will be decreased, not increased. Okay, when VA decreases, the ratio will decrease. Okay, may be determined from the respiratory minute volume and the pulmonary blood flow. Let's see. The next option is expected to increase following the blockage of major pulmonary artery. So when we block the pulmonary artery, the perfusion is decreased, which decreases the which increases the ratio. When the denominator is decreased, the ratio will increase. Okay, it's clear, right? I hope so. So the next question, with respect to gas exchange across the alveolar membrane. Okay, now we are going to talk about the hemoglobin oxygen dissociation curve. We know it shows the saturation of the oxygen with the hemoglobin. Okay, the two main things you should remember for the upcoming questions and for tomorrow's exam is, I'll just write here, the right shift and the left shift of the hemoglobin oxygen dissociation curve. What are the factors causing the right shift and what are the factors causing the left shift? For that, just understand the right shift means low oxygen affinity, or the hemoglobin cannot hold the oxygen tightly, which happens in the tissues, so that the hemoglobin can release the oxygen and tissues can take them. Here, just understand everything is increased temperature, increased carbon dioxide, increased hydrogen ions, or which is basically decreased pH. Okay, also increased 2,3-DPG, which is diphosphoglycerate, uh, which is formed as a result of metabolism of the RBCs. Okay, so these factors, increasing in temperature, increasing cardiac output, increasing in the hydrogen ions, or increasing in the 2,3 diphosphoglycerate, causes the right shift of the hemoglobin oxygen dissociation curve. Next, the left shift, just the opposite factors, decrease in temperature, decrease in carbon dioxide, decrease in H plus, or increase in pH, both are the same, also with decreasing 2,3 diphosphoglycerate. Okay, there are two other factors causing the left shift, which are carbon monoxide poisoning and fetal hemoglobin. Okay, You should be absolutely clear with these two, because for tomorrow's exam there will be one or two questions definitely from this topic. Okay, so let's go to the question. With also one thing, the right shift occurs at the tissues and the left shift happens at the lungs. Okay, increased O2 affinity. The hemoglobin can hold the oxygen tightly, which is basically happening in the lungs. Okay, so the option fever causes oxygen hemoglobin dissociation curve shift to the left. Is that correct? Increasing in temperature, which is fever, causes right shift, not the left shift. Okay, increasing temperature causes right shift, not the left shift. So that is wrong. Okay, an increase in 2,3 diphosphoglycerate causes the oxygen hemoglobin dissociation curve to shift right. Is that correct? Yes, and increasing DPG shift the oxygen dissociation curve towards the right side. That is correct one. What are the next options? Oxygen dissociation curve of fetal hemoglobin is causing left shift here, not right shift. Okay, excise shifts the oxygen. Excise means increasing in temperature, increasing carbon dioxide, etc. causes what? Right shift. See, okay, increasing temperature and increasing in carbon dioxide causes the right shift of the oxygen hemoglobin dissociation curve, not the left. So the correct option is option B. Okay, so just know these factors causing a right shift or a decreased oxygen affinity, or and the factors causing the left shift or the increased oxygen affinity. Okay, the oxygen, next question, the oxygen hemoglobin dissociation curve will shift to right. Okay, again right shift, as I said. Okay, decreased O2 affinity, everything is increased here, right? Increased temperature, increased carbon dioxide, increased H plus or decreased pH, and also increased 2,3 diphosphoglycerate. Okay, so acute alkalosis, no, causes what? Acidosis, right? What is next? Decrease in PCO2, no, increase in PCO2. Okay, not decrease. Decrease in temperature, no, increase in temperature causes right shift. Okay, exercise is basically increase in temperature and increase in carbon dioxide causes right shift. Okay, easy. Let's go to the next question. Oxygen unloading happens where? At the tissues. Okay, so there will be what? Right shift. Okay, oxygen unloading means decreased O2 affinity, which is at the right shift. So again increases with the increased PCO2. No, next decreases with the increase in temperature. No, increases with increase in temperature, decreases with the increase in, no, that is wrong. Okay, increases with the increased PCO2. Yes, increased PCO2, increased temperature, increased hydrogen ions. Okay, and increased 2,3 DPG. Okay, so again, once again, The option first one is increase with the increased carbon dioxide. Yes, that's correct. uh, Increases unloading, or the right shift increases with the increase in carbon dioxide. Okay, concentration of carbon dioxide. Next is decreases with the increase in temperature. No, it also increases with the increase in temperature. Decreases, no, increases with the increase in diphosphoglycerate. Increases with exposure to carbon monoxide poisoning. No, it causes left shift. Okay, so the correct answer will be option A. Easy. Factors that cause shift of the oxygen curve to the right. Again, increased dpg. Yes, acidosis means increased H plus or decreased pH. That's correct. Increased temperature. Yes, all of the above are correct answers. Causes right shift. Okay, again. Okay, okay, so the diagram is missing. Okay, I'll just draw the diagram. Okay, this is curve A and this is curve B. Okay, nothing. So the shift from curve A to curve B, shift from curve A to curve B. So there is what? Right shift, right shift, right shift. There is increased pH. No, there is decreased pH. Okay, decreased diphosphoglycerate. No, there is increased diphosphoglycerate. Sternus exercise. Yes, there is increased temperature, increased carbon dioxide, etc. So that is the correct option. Fetal hemoglobin causes left shift. Clear? Okay, just know what is the shift, and we know the factors causing right shift and the left shift. The next one is during chloride shift. So what is chloride shift? Okay, let's get to that. At the tissues, when the carbon dioxide produced by the tissues enters the blood, the carbon dioxide, sorry, the carbon dioxide enters the RBC, okay, where it combines with the water to form carbonic acid, which gives dissociates into H plus hydrogen ion and HCO3 minus bicarbonate. Okay, with the help of carbonic anhydrase enzyme. So when the bicarbonate concentration is increased inside the RBC, the bicarbonate tend to move out of the RBC in exchange with the chlorine. Okay, so the bicarbonate is being produced inside the RBC. When there is increased concentration of bicarbonate inside the RBC, the bicarbonate tends to move out of the RBC into plasma in exchange with chlorine. The chlorine enter inside the RBC, which is known as the chloride shift. Okay, so we can check the options during chloride shift. Option A, bicarbonate enters the RBC in exchange with the chlorine. No, bicarbonate leaves the RBC, not enters. See, bicarbonate leaves the RBC. Okay, chlorine gets inside the RBC. A red cell in arterial blood shrinks. Okay, let's see. When the chlorine is being transported inside the RBC, bicarbonate is already being produced from the carbon dioxide and water, and the chlorine is being introduced inside the RBC now. So the concentration of both chlorine and bicarbonate increases inside the RBC, which will cause a increase in size or volume of the RBC. Okay, swells up the RBC. So red cell in the arterial blood does not shrink, it swells up. Okay, blood becomes more acidic. Is that right? Here, along with the bicarbonate, free H plus is also being produced. Most of the H plus or the free hydrogen ions will be buffered by the deoxyhemoglobin, the hemoglobin which does not have the oxygen. Okay, it will buffer the free hydrogen ion, but still there will be a slight acidic in the venous blood. Okay, so the blood becomes slightly or more acidic. Okay, what is the last option? RBC's size in the arterial blood is increased. No, RBC size is increased, but not in the arterial blood, but in the venous blood. Okay, so the option will be C. Clear? Okay, let's go to the next question. Okay, most of carbon dioxide is transported in the blood in the form of easy. The blood in the blood, carbon dioxide is transported in the form of dissolved gas, yes, carbaminohemoglobin, yes, and by carbonate ion. But the most amount, more than nearly to 90 percentage, transported by us by carbonate ion. Okay, as we discussed in the previous question. Okay, the same question repeated again. About 90 percentage of the carbon dioxide is transported to lungs in the form of bicarbonate ions. Okay, easy. The same question. Okay, next. During the release of carbon dioxide in the lungs. Okay, so we discussed what happens at the tissues with carbon dioxide. Just the opposite happens at the lungs. Let's see. RBC, the oxygen binding with the hemoglobin displaces the H plus ion and as well as the carbon dioxide from the hemoglobin. Okay, that's what happens. So now there is free H plus inside the RBC, which the hemoglobin displaced. Okay, the HCO3 or the bicarbonate in the plasma will move towards or inside the RBC in exchange with the chlorine. Okay, the chloride shift in an opposite way. Okay, and inside the RBC, both H plus ion and bicarbonate combine to form carbonic acid and gives H2O and CO2, where the carbon dioxide can be expired. Okay, so let's see the option. The binding of oxygen to hemoglobin displaces carbon dioxide. Yes, the binding of oxygen to hemoglobin causes release of hydrogen ions. Okay, the binding of oxygen to the hemoglobin at the lungs causes the displacing of both the hydrogen and the carbon dioxide. Okay, the hydrogen ions combine with the bicarbonate to form carbonic acid. Yes, the hydrogen ion with the carbonic acid forms the the hydrogen ion with the bicarbonate from the carbonic acid. Okay, so all the statements are correct. Okay, next question. In the transport of CO2 from the tissues to lungs, which of the following occurs in the venous blood? Just what we discussed now. Conversion of CO2, conversion of CO2 and H2O to H plus and HCO3 minus in the red cells. Yes, that occurs at the tissues, right? Buffering of hydrogen by oxyhemoglobin. No, by deoxyhemoglobin. Okay. shifting of bicarbonate into RBC from plasma in exchange. No, this happens at the lungs. Okay, bicarbonate gets inside the RBC and chlorine leaves at the lungs. At tissues, what happens? Just the opposite. Bicarbonate leaves the RBC in exchange with the chlorine. Binding of bicarbonate to hemoglobin. No. So the correct option is option A. Okay, option A. Let's go to the next question. The pH of venous blood is slightly more acidic than the pH of arterial blood. We discussed this topic already during chloride shift. The carbon dioxide present inside the RBC combines with the water to form carbonic acid, and it the carbonic acid is then forms free hydrogen ions and bicarbonates. Okay, so even though the free hydrogen ions are buffered by the deoxyhemoglobin, there will be a slight acidity change. Okay, but think if these free ions are not being buffered, there will be high acidity. So they asked why there is a only slight change, because the ions are, or the hydrogen ions are being buffered by the deoxyhemoglobin. The hydrogen generated from the CO2 and H2O is buffered by the deoxyhemoglobin in the venous blood. That is the correct option. Okay, the next one, carbonic anhydrase. We know inside the RBC, carbon dioxide combines with water in the presence of what? Carbonic anhydrase to form carbonic acid. Okay, is present in the plasma? No, is present in the erythrocytes or the RBC. Okay, catalyzes the reaction between carbon dioxide and hemoglobin? No, carbon dioxide and water. Catalyzes the decomposition of carbonic acid into bicarbonate and hydrogen ions? No. Okay, next question concerning the interaction of respiratory centers in the brainstem. Okay, so towards the last chapter, right? The first portion, let's discuss about the respiratory centers. Listen, this, let's imagine this is the midbrain part of the pons and the medulla of the brainstem, and this is the pons, and we have medulla. Okay, there are two respiratory centers in the pons. Okay, pontine respiratory centers, which are PNC or pneumotaxic center, APC or apneustic center, and there are two medullary respiratory centers, towards the dorsal side, that is dorsal respiratory group, and towards the ventral side, that is the ventral respiratory group. Okay, so this is the basic arrangement of the respiratory centers, and above the or towards near to the VRG or the ventral respiratory group, we have a small group of cells, pacemaker cells, known as pre-Bodzinger complex. Okay, this one. Now let's see the options. Okay, we should know the effects too. Okay, the effects. So the pneumotaxic center, PNC, helps in switching off the inspiration and starting the expiration. Okay, offing the inspiration and starts the expiration. Apneustic center for inspiration, DRG for inspiration, and VRG. The inspiration caused by DRG will be irregular. Okay, it is regulated by the Pondine centers by PNC and APC. Okay, the VRG, inspiratory, both inspiration and expiration, but inspiratory during forced inspiration. Okay, that is the basic, okay, basic thing, work of these centers. So let's see the options. Sectioning the brainstem above the pons result in immediate respiratory arrest. Sectioning the brainstem above the pons. No, still the what? The centers, respiratory centers are intact. So there won't be any respiratory arrest. The second one, the medullary center is a discrete group of neurons whose rhythmicity is abolished when the brainstem is transferred above or below. Not both above and below, only when it is transected below this area. Okay, the next, transection above the apneustic center results in prolonged breathing. Not above the, okay, yes, the transection, see, the transection above the APC causes what? Prolonged inspiration and very short duration. No, transaction below the APC causes prolonged expiration. Okay, the last option, transaction of the efferent fibers of the vagus and glossopharyngeal nerves result in prolonged inspiration. Okay, listen, the vagus nerve starts from the stretch receptors in the lung towards the PNC and towards the DRG, gives the inhibitory signals or to stop the inspiration. So if the vagal nerve and the glossopharyngeal nerves are being transected, then switching off inspiration does not takes place, causing prolonged inspiration and shortened expiration. Okay, is that clear? In this case, transaction above the APC destroys the PNC, but still the vagus nerve is intact. Okay, let's go to the next question. The most potent stimulator of the respiratory center. So for that, we should talk about the chemoreceptor, respiratory chemoreceptors. Okay, we have two types: central chemoreceptors and peripheral chemoreceptors. Central chemoreceptors in the CSF monitor the changes in carbon dioxide. So, in central chemoreceptors, their primary stimuli is actually hydrogen ions, but the hydrogen cannot pass the brain blood barrier and enter the CSF. So, who can cross? Carbon dioxide can cross this barrier, and in CSF they combine with the water, forming carbonic acid, and then dissociated into hydrogen ion and bicarbonate. So carbon dioxide in turn increases the increasing carbon dioxide in turn increases the hydrogen ion, which act as the secondary stimuli. Okay, clear? In peripheral chemoreceptors present in two sites, which are at carotid body and at a aortic arc. Okay, glomus cells, basically glomus cells present at carotid body and aortic arc. Now, the central chemoreceptors are sensitive to increase in carbon dioxide. Okay, the peripheral chemoreceptors mainly they are sensitive to lack of oxygen or decreased oxygen. They're also sensitive to increase in carbon dioxide and increase in H plus. Okay, keep this in mind. The central chemoreceptors are most sensitive to the change in carbon dioxide or increase in carbon dioxide. The peripheral chemoreceptors are more sensitive to lack of oxygen, increase in carbon dioxide, and increase in hydrogen ions. Okay, so let's go. The most potent stimulator of the respiratory will be what? The central chemoreceptors, which constitute 85 percentage of the uh, control. So central chemoreceptor, the stimuli is increasing carbon dioxide in blood. Okay, is that clear? Okay, let's go to the next question. Respiratory chemoreceptors, we just discussed it. Okay, let's see the options. In the carotid and aortic bodies, yes, most important ventilatory response to the elevated PCO2. No, the peripheral chemoreceptors are most important in the ventilatory response to decreased O2. Okay, in the carotid and aortic bodies, the peripheral chemoreceptors are strongly stimulated by low alcohol content in the anemic patients. No, in anemic patients, see, they monitor the PCO2 and PO2. The peripheral bodies or peripheral chemoreceptors monitor the PO2, which is the what? The dissolved oxygen, not which is combined with the hemoglobin. Okay, so not arterial O2 content. In the medulla are responsive to change in arterial PCO2. Yes, that is correct, right? CSF, in CSF CO2, central chemoreceptors option. Okay, there is a small problem in this option, so just don't take it. The correct option is option C. Okay. Okay, the next question. Which of the following discharge spontaneously during the quiet breathing? So, during normal breathing, I told you the medullary part or the DRG, which helps in inspiration, is spontaneously being discharged. Okay, there is other group VRG only during forced inspiration. Okay, okay, So DRG is the correct option. Okay. Stretch receptors discharge impulse when the lung is stretched or after the inhalation or inspiration. Okay, next question. A stroke that destroys the respiratory area of the medulla. Okay, so the respiratory area, whole respiratory area of the medulla is expected to lead to which of the following? So the respiratory centers are destroyed. So no more breathing takes place. Immediate cessation of breathing is the correct answer. Okay, if it destroyed the pontine regions only, then irregular breathing will be there because the medullary part DRG uh, can start inspiration, okay, but in a irregular manner. But here the medullary respiratory centers are destroyed. Okay, next question. Pneumotaxic center or the PNC. I told you the function is to stop inspiration and start expiration. Okay, limit inspiration. Okay, easy. The next question. The basic rhythm of respiration is generated by neurons located in the medulla. Okay, what limits the duration of the inspiration? Okay, so who stops the inspiration? Just as we told, inspiration is stopped by pneumotaxic center and also by vagal stimulation. So in the options, pneumotaxic center. Easy. Next question. When the respiratory drive for increased pulmonary ventilation becomes greater than normal, a special set of respiratory neurons are inactive during normal quiet breathing becomes active. So in case of forced inspiration, a special set of respiratory center become active, which are VRG, as we discussed. They work during forced inspiration, not during normal inspiration. Okay, the next question. The afferent sensory endings of herring brewer reflex, which is nothing but the vagus nerve. Okay, are mechanoreceptors located in the, as I told you, vagus nerve have the mechanoreceptors at the stretch receptors of the bronchi and bronchioles. Okay, stretch receptors of the bronchi and bronchioles. The next question. Okay, peripheral chemoreceptors. Again, the peripheral chemoreceptors which are present at the aortic arch and carotid body. Okay, are stimulated mainly by lack of oxygen. Okay, also to a slight amount by increasing carbon dioxide and increasing hydrogen ions. So stimulated by, yes, first option, hypoxia. Hypoxia is what? Lack of oxygen. Okay, easy. Okay, the next question. Hypoxemia produces hyperventilation by direct effect on. The same question asked in a different manner. Hypoxemia means decreased O2, which stimulates the what? The peripheral chemoreceptors. Okay, at the, where are they present? At the carotid and aortic body. Is that clear? I hope so. Okay, let's go to the next question. All about the peripheral chemoreceptor is true except, okay, we should find the false statement, are located at the carotid sinus. Is it? No, not at the carotid sinus but at the carotid body. So this is wrong. Let's see. Located the aortic body, yes. Have a rich blood supply, yes. Respond to changes in the arterial PO2, yes. Lack of PO2. So the option is option A, which is the wrong statement. Okay, let's go to the next question. The activity of central chemoreceptors is stimulated by, again, the central chemoreceptors will be stimulated by the change in carbon dioxide in the blood. Okay, so an increase in PCO2 of blood flowing through the brain. That is the correct option. Okay. Okay, let's go to the next one. Hypoxic hypoxia. So let's talk a little bit about hypoxia. Okay, we have four types of hypoxia, which are hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and last, histotoxic hypoxia. So hypoxia means lack of oxygen. The difference is, in hypoxic hypoxia there is a problem with what? The oxygen diffusion. Okay, the oxygen diffusion, the oxygen is not able to get diffused into the blood. In the second type, anemic hypoxia, there is no problem with the oxygen diffusion, but the problem is with the oxygen saturation or with the hemoglobin. Okay, binding to hemoglobin. The next one, stagnant hypoxia, there is no problem with O2 diffusion or no problem with the hemoglobin. The problem here is with the blood flow. Histotoxic hypoxia, here there is normal O2 diffusion, normal hemoglobin, normal blood flow, but the problem is with the cell. The cells or the tissues cannot utilize the oxygen in the blood. Okay, this is about hypoxia. And what is cyanosis? Cyanosis means special characteristic blue color of the skin and the mucous membrane, which is due to the increased volume or amount of increased concentration of deoxyhemoglobin. Increased concentration of deoxyhemoglobin, which is greater than 5 leads to cyanosis, means the bluish discoloration of the skin and the mucous membrane. Okay, is that clear? Okay, now does all the hypoxia shows cyanosis? No. Let's see. In hypoxic hypoxia, there is a problem with the O2 diffusion, means the oxygen cannot bind with the hemoglobin, so the deoxyhemoglobin or the reduced hemoglobin will be higher in number, so this shows cyanosis. Okay, in anemic hypoxia, the number of hemoglobin itself is reduced, so both oxyhemoglobin and deoxyhemoglobin is reduced, so there won't be any cyanosis. Okay, in stagnant hypoxia, the blood flow is very slow, so the tissues will take oxygen from all the or most of the hemoglobin, leaving more and more higher number of hemoglobin reduced, or the concentration of reduced hemoglobin, deoxyhemoglobin, is increased, which leads to cyanosis. Okay, the last one, histotoxic hypoxia. Here the cells cannot use the oxygen, so the oxygen will not be dissociated from the hemoglobin, so there won't be higher level of deoxyhemoglobin and no cyanosis. Okay, this is the outline about hypoxia and cyanosis. Now let's get back to the questions. The question is about hypoxic hypoxia. The problem is with the oxygen diffusion, is characterized by normal oxygen tension in arterial blood and normal saturation with hemoglobin. No, there is no normal oxygen in the arterial blood. Is accompanied by cyanosis. Yes, that is correct. Is produced by carbon monoxide poisoning. No, carbon monoxide poisoning in anemic hypoxia. Okay, is accompanied with low hemoglobin content. No, again anemic hypoxia. Okay, the next question. In normal individual, respiration is regulated by all except, okay, okay, which is the wrong statement. Central chemoreceptors responding to change in PO2. That is a wrong statement, because central chemoreceptors respond to the change in PCO2, not PO2. Peripheral chemoreceptors respond to the change in PCO2. Yes, peripheral chemoreceptors change responding to changes in O2. That is correct. Central chemoreceptors respond to changes in PCO2. This one is correct, and the first option is the wrong statement and the correct option. Okay, so let's go to the next question. We are going to wind up in just 10 minutes. Okay, so the next question is, the carotid and aortic bodies increase their rate of discharge in response to. So carotid bodies and aortic bodies are nothing but what? Peripheral chemoreceptors, right? These increase the rate of discharge in response to lack of oxygen, increase carbon dioxide, and increased H plus. Okay, so blood H plus concentration is correct. Blood O2 content is wrong. Why? O2, not O2 content, but PO2, or the dissolved oxygen. O2 content is the oxygen attached to the hemoglobin, saturated with the hemoglobin, not the O2 content, but the physically dissolved oxygen or the partial pressure O2, PO2. So both, the third option is the partial pressure of blood oxygen. Correct answer is both A and C. Okay, the next question. Which of the following is a characteristic of emphysema but not pulmonary edema? See, in emphysema, the lung loses its tendency to recoil. Okay, it has higher stretching. Okay, but in pulmonary edema, there is fluid accumulation, so it loses the lung compliance or the stretching. Okay, option hypoxemia. No, a diffusion barrier is created between the alveolar air and the blood. That is not the difference. Abnormally high compliance. Okay, high compliance means high stretchability is a characteristic of emphysema but not pulmonary edema. Okay, next question. Which of the following conditions would limit the diffusion of O2 from alveoli to pulmonary capillary blood? Okay, again, which of the following conditions would limit the diffusion? Okay, we remember the rate of diffusion, right? uh, of O2 from alveoli to the pulmonary capillary blood. Breathing hyperbaric gas mixture means higher pressure oxygen will increase the rate of diffusion. Chronic obstructive lung disease, increased ventilatory rate, and pulmonary edema. Which should limit the diffusion? Of course, pulmonary edema, because the thickness is increased. So rate of diffusion is inversely proportional to the thickness. If the thickness is increased, rate of diffusion is limited or reduced. Okay. Okay. Next question. Cyanosis. About cyanosis, can be seen if the capillary blood contains 5 mg reduced hemoglobin. No, more than 5 mg. Okay, more than 5 mg. Is observed in histotoxic hypoxia? No. Is observed in where? Hypoxic hypoxia and stagnant hypoxia. Okay. Is seen in carbon monoxide poisoning? No. In carbon monoxide poisoning is what? Anemic hypoxia, which does not have no cyanosis. Okay. The last option is present in severe ventilation perfusion imbalance. Severe ventilation perfusion imbalance causes what? Problem with the oxygen diffusion, which is hypoxic hypoxia, in which cyanosis is present. So the correct option is option D. Okay, we have one more question, the last question. Okay, a 17-year-old male breathes in and out of a paper bag. Okay, so he is continuously breathing in and out of a closed paper bag. His rate of breathing continues to increase. Which of the following is responsible for the increased ventilation? So imagine he is breathing in and out from the same paper bag. So by the time the paper bag will have higher concentration of the expired carbon dioxide, so he will be again inspiring these high concentration of carbon dioxide. Okay, so increased concentration of carbon dioxide in the blood, okay, in the alveoli, causes what? Increased hyperventilation for removing the excess carbon dioxide. So he is taking back the carbon dioxide which he expired again. So the partial pressure of carbon dioxide inside the alveoli will be higher. Okay, which is responsible for the increased ventilation. So the option is option B. So we have almost covered all the topics in the respiratory portion of the physiology. I have discussed some major topics too, so this will be helpful for tomorrow's exam. I hope the exam will be very easy. Okay, just go through the questions and the topics again. And now Anu will carry on with the cardiac portion of the physiology. And that's all. Thank you. It's my pleasure, and see you again.